Good evening, everybody. Thank you so much for joining the Living with Thyroid Eye Disease Patient and Caregiver Virtual Education event. We're going to go ahead and get started, and I'm going to go ahead and ask our two speakers, Seth and Dr. Korn, if they will go ahead and flip on their cameras and they can give a wave to everybody who is on our webinar today. I'll give a bit of an introduction about them in just a couple of minutes. But the first thing I'm going to do is I'm going to go ahead and share my screen, and I'm just going to run through a little bit about what this webinar is today, some of the items that we're going to be talking about, and who is going to be talking about them. As I mentioned, this is called Living Well with Thyroid Eye Disease, a patient and caregiver virtual education event. And today's webinar is hosted by the Alliance for Patient Access, and it's hosted by the Vision Health Advocacy Coalition, which is a project of the Alliance for Patient Access. Today's agenda is as follows. My name is Susan Hepworth. I'm with the Alliance for Patient Access and the Vision Health Advocacy Coalition. I'm coming to you from Washington, D.C., where it is quite a bit later than it is for all of you who are attending this, mostly on the West Coast tonight. Following my brief remarks, we're going to hear from our first speaker, and that is Seth Ulinski. Seth is a thyroid eye disease patient advocate, and he's coming to us tonight from Dover, New Hampshire. Following Seth's remarks, we will hear about Thyroid Eye Disease 101, and we're going to hear tonight from Dr. Bobby Korn. He's a professor of ophthalmology and plastic surgery at the Shiley Eye Institute, and he's coming to us from San Diego, California. Following Dr. Korn, we have set aside about 30 solid minutes just for question and answer. So we want everybody who is attending tonight to ask as many questions as possible, and we've allotted a lot of time at the end for both Seth and Dr. Korn to be able to answer as many questions as everybody has. And then I'll just give a couple of closing remarks, and we will wrap up at about 8:30 p.m. The Alliance for Patient Access, who's hosting tonight's event, was founded in 2006, and AFPA, as we call it for short, is a network of policy-minded healthcare providers who are really focused on advocating for patient-centered care. So looking at policies that will reinforce clinical decision-making, really go to personalized care and protecting that physician-patient relationship that we all know is very important. The Vision Health Advocacy Coalition, which is a project of the Alliance for Patient Access, is really just a coalition of stakeholders that promotes patient-centered policies that make services, devices, and treatment accessible for people with a variety of vision conditions. The Vision Health Advocacy Coalition undertakes a lot of different awareness and education activities and campaigns around a variety of different vision conditions. So you can see there we've got something about age-related macular degenerations, Sjogren's, dry eye, all sorts of different things, glaucoma. But obviously tonight we're going to be talking about thyroid eye disease. We produce a variety of policy papers, infographics, videos, all aimed at raising awareness and helping people to understand what policies are important to ensure that patients have access to whatever it is that their physician prescribes to them, whether that is a medication, a diagnostic, or a procedure. We would encourage you after the webinar to visit us online at visionhealthadvocacy.org, and then you can also find us Vision Advocacy on Facebook and Twitter, and then AFPA Patient Access for all of the videos on YouTube. So this is the really important part. This is how you're going to be able to ask questions. And remember, I said we allotted about 30 minutes at the end for questions, but you don't need to save your questions until we get to the end there. At any time during the webinar, you will see down on the bottom bar of your screen, you'll see a chat icon, raise hand, and Q&A. So if you just want to click on that Q&A box at any time when Seth is talking, when Dr. Korn is talking, when I'm talking, you can go ahead and type in your question to us. I'll be keeping track of all of those. And once we get to the end, I will start reading through the questions, and Dr. Korn and Seth will knock out as many of those as we can. So I really encourage you to ask a lot of questions. The more questions are asked, the better, in my opinion, and that's why we allot so much time for it at the end. So again, feel free to ask anything you want, and don't feel like you need to wait until the end of the webinar in order to ask that question. Just go ahead and click that Q&A box, type in whatever your question is, and we'll get to it at the end. So I will go ahead and turn it over to Seth to talk about the patient experience.
Thank you, Susan. So my name is Seth Ulinski. I live in Dover, New Hampshire. And yeah, it's an honor to be able to share a story about something that not a whole lot of people experience, and it's unique to each individual. And hopefully by me sharing some of my thoughts and experiences, I can help some of those out there maybe have a little bit better go at this disease. And we can move forward. Here's my mugshot, official, and moving forward. So this is a quote I provided a few months back when there was a therapeutic drug going to market. And if the eyes are the window to the soul, then thyroid disease is a soul-crushing disease. And you really have to walk in someone's shoes to understand their experiences and what they've kind of gone through and felt. So I thought, just based on my experience and understanding how important eye health is, kind of after the fact, a lot of people take it for granted. And you know, certainly thyroid eye disease is just one of many eye diseases out there, but just the way that it presents itself, and again, it's a rare disease, and there's not a whole lot of really solid treatments out there currently. There's a lot of, I guess we'll say, drugs that are being developed right now are kind of in test phase that hold a lot of promise. But basically, when I was diagnosed about 12 years ago or so, there really wasn't a whole lot I could do besides hurry up and wait. And that was probably the toughest part about it. So moving forward, again, some of those who are joining us may be pretty familiar. If you're not, some of the active phase symptoms include bloodshot eyes, proptosis or bulging of the eyes. This, of course, can be a sudden or drastic change in one's appearance. And definitely when you start talking about the impact of TED, some of the physical impact it can have is on borderline debilitating, depending on who you talk to. I was fairly fortunate that my case was considered mild, but even in a mild case, I think anytime after you reach adulthood and you've kind of come to identify yourself as looking a certain way, and then over the course of a few months, it can be altered pretty drastically. That's a lot to have to deal with and take on. And again, I mentioned hurry up and wait. The disease presents itself and kind of takes its active form for, you know, it could be 12 months, 16 months, 18 months, 2 years. It really depends on the individual. And again, not knowing is really difficult when you're dealing with any kind of a health setback. And then for, I would say, the vast majority of folks who deal with TED, they're most likely dealing with thyroid disease as well. As in my case, I had thyroid disease or Graves' disease for about a year before I was diagnosed with TED. And we can move forward. So once I was in touch with my primary care physician and getting some guidance from her, I ended up having to kind of do some additional homework and figuring out who I needed to speak with, endocrinologist, ophthalmologist, and then kind of the last stage for me was an oculoplastic surgeon. These are difficult to pronounce, so people probably aren't familiar with them in the first place, but suffice to say they each play a very different role most of the time, depending on, you know, what area of specialty they're in. And for anyone that's managing TED, I would, you know, strongly encourage them to kind of brush up on the various roles of these specialists play and how they can, you know, communicate and benefit from meeting with them. And moving forward. So in my case, again, I think I'm like anyone else in this society today. We're all about here and now, and if we want something, we want it kind of on demand. And unfortunately, with thyroid eye disease, it's not that easy. And again, there's not a whole lot of aggressive treatments you can undergo or take on when you're diagnosed until you're in the non-active phase. And that waiting period is really tough. And when you're kind of going through this, it's almost like a metamorphosis or changing your appearance. Trying to manage that along the way while you're managing the more day-to-day aspects of living with thyroid disease or TED is kind of coming to grips with how you look and then how others view you, and it can be a little bit tough to swallow. So I'll give one example. I hadn't seen one of my friends for probably 8 or maybe 10 years, and I was in the active phase, and I showed up at his barbecue, and he comes up to me and he asked me if I'm high, and I was completely sober. So that was really kind of gut-wrenching because I had this narrative in my head many times. People are judging me, people are looking at me, and then to have a friend of mine jokingly, but he had no idea what I was going through, make a comment like that just kind of cemented this kind of horror show that I had playing out in my head, that people were seeing me and thinking I was, drinking or high or what have you. So yeah, that's one aspect of kind of the mental component of this disease that I think is kind of flown under the radar, like mental health in general. So happy to talk about that a little bit more and moving forward. So finances, being sick is never inexpensive. So the out-of-pocket expenses for TED are pretty significant, and I had to take eye drops that would have probably cost me upwards of $350 to $400 a month out of pocket had I not had insurance. And when you're already dealing with all of the other aspects I already mentioned, have to consider the financial burden of this at the same time. That can really weigh on somebody a lot. So, just talking about the various elements here, but again, happy to kind of dive into any areas that are more interesting than not. And moving forward. So today, I can say I've recovered fully, inactive. I hadn't had any recurrences or flare-ups of TED, so I'm very grateful for that. But I've also been smart to not smoke and eat healthy and take care of myself, living a healthy lifestyle. So fortunately, I wasn't a smoker when I was diagnosed, and I never really got into smoking. So that was one kind of mark on my side, I guess, as far as managing TED. Going back to the mental health, it's interesting to look back now and think about how I kind of changed the way I operated in work and social settings based on how I looked. It was something as simple as wearing my eyeglasses, which were prescribed for computer and reading work. I wore them all the time, and those glasses were more or less like a mask for me, where I felt like people couldn't quite see my eyes as clearly, and that was a good thing as far as I was concerned. It sounds very trivial or small now, but when you're doing that constantly and constantly wondering what other people are thinking about you and so on, it can weigh on you. But today, I would definitely say there's a lot of resources and things that are readily available that were not there when I was diagnosed, say, 12 years or so ago. So the AFPA doing these seminars or webinars on eye health, for example, allow people to communicate, from my side as well as Dr. Korn's, where you can really kind of have a 1-2 punch at a disease that's not really well understood, versus back when I was initially diagnosed. I don't think there were initiatives and organizations quite like this that were out there, looking to help people understand it and, leverage resources and gain knowledge. So it's a different time, and I'm excited to be part of it. Back to you, Susan.
Great, thank you, Seth. Let's try to turn my video back on here. Hopefully everybody can see me. I'll stop sharing. Okay, and as just a reminder, I think we've already actually gotten a couple of questions, which is great. So just a reminder, down in the bottom of your screen, there's a Q&A box. Go ahead and type in questions at any time during Dr. Korn's presentation, and we've reserved time at the end that we will start to go through those. So Dr. Korn, I'll turn it over to you.
Great, everything's looking good, sounding good?
Yep.
All right, great. Well, Susan, thank you very much for the invitation to speak here, and it's my honor to speak, to the AFPA and all of our attendees listening. I'm going to give you just sort of a thyroid disease 101, and there's a lot of lectures out there on the internet about thyroid eye disease, and I'm going to give you my own flair or flavor, how I treat patients and how I approach this condition. These are my disclosures. I am a consultant with Horizon, and I will be discussing one of the medications that Horizon produces in regards to the use of thyroid eye disease. So please keep that in mind throughout our talk. Let me really thank you for your time and attention. And I showed this slide here because it really just reemphasizes to me that, you go through all these years in medical school, you study all this knowledge in the book, and then when you meet your patients for the first time, you find that they teach you so much more about the condition, and you learn things that you really can't pick up, in a textbook and reading. And just hearing Seth talk, it really just, gives me all these memories of all the patients who I've seen over the years who have taught me so much about the condition. You read about all these things with apoptosis and lid retraction and how it affects your life, but when you hear it in the patient's eyes and how it's really affected them in their lifestyles, it really hits home to you, and it really motivates you as a physician to do everything you can to give your patients sort of the best possible outcome. So let me get into my talk here. And the way I organized this talk was really to do it as more of a FAQ, a frequently asked questions. And what are some of the questions that patients ask me? And then what I'll do is I'll lead into some of the pathophysiology of the disease and how we treat this. And of course, there've already been a couple of questions that come up in the Q&A and chat. Please feel free to type those in. We'll try to knock those off like one by one, during the Q&A period. So one of the first questions that patients often ask me is, what causes TED, TED, or thyroid eye disease? Well, thyroid eye disease is an autoimmune condition. What do we mean by that? Well, an autoimmune condition is where your body somehow starts attacking normal components of your body. And the immune system, one of the different arms of it, is the humoral side, where you develop antibodies. So say you were to get an infection by a bacteria or a virus. You're not accustomed to this. Your body's never seen it before. Your body will develop antibodies against this foreign invader and ward it off. In the case of an autoimmune condition, such as thyroid eye disease, somehow the body looks at the eye and the thyroid gland as a foreign invader. And what it does is it creates antibodies directed at various tissues in the eye and the thyroid. And that causes a lot of the symptoms that we see: bulging of the eyes, enlargement of the thyroid gland. And a common question that patients will ask me is, well, Dr. Korn, I'm about to have radioactive iodine. That'll get rid of my thyroid. I might even have a thyroidectomy. If I get rid of my thyroid gland, won't my eye disease get better? And the answer is no, because it's the immune system here, that part of your body that is fighting infections, that is actually causing the disease. So taking a thyroid out does nothing to your eye. Obviously, we wouldn't take our eyes out, because we wouldn't expect that to have a function or effect on the thyroid, having a large goiter. So keep that in mind, okay? We don't want to obviously get rid of the immune system, because then we'll be susceptible to many different diseases. So another question that comes up for my patients is specifically related to what causes thyroid eye disease is, what's happening in the cells, right? And through many, many decades of research and work done by Terry Smith and many other scientists around the country and around the world, we found that thyroid eye disease, when you really look at the tissues inside of the eye socket, is focused on one central player, and that's this tissue here called the orbital fibroblast. And we find that amongst the many different things that go wrong in the orbital fibroblast is that we have overexpression of this molecule here called IGF-1R. And we know that throughout the life of a thyroid patient, this molecule is elevated. And because this is an autoimmune condition, the body develops these what are called autoantibodies, antibodies that are directed at our own tissues that activate this IGF-1R receptor and this protein here called the thyroid stimulating hormone receptor. And these two molecules here activate the orbital fibroblast and they kick it into overdrive. And what this fibroblast does is it makes a lot of tissue called hyaluronin and glycosaminoglycans. And this is the molecule that causes enlargement of fat and the muscles in the orbit, causing the eye to push out. So if we look here on the top here, this is a normal eye here. That's the eyeball. These little pink strands here are the muscles that move your eyes. And these little yellow circles here is the orbital fat, which cushions our eye. In thyroid eye disease, these muscles get really large and the fat expands here. And I'll show you some scans in just a minute of what that actually looks like and what we see as physicians. The next question that often comes up is, am I alone? Do other people have this? How common is thyroid eye disease? Well, there was a study done over 20 years ago at the Mayo Clinic by Dr. George Bartley in Olmsted County, Minnesota. And he did a very exhaustive search looking at all the patients at the Mayo Clinic. And what he found was the incidence of thyroid eye disease was approximately 30 cases per 100,000 persons per year. If you extrapolate that just to the US population, we're looking at almost 100,000 patients a year with thyroid eye disease, right? And if you further segregate that, you find that women are disproportionately affected much, much more than men. There's about an 8 to 9 to 1 ratio of females affected compared to males. Now, the next question patients often will ask me is, why do my eyes hurt all the time, right? And I already talked about with thyroid eye disease, your elevation of all these abnormal antibodies in the body causes your eye, particularly the tissues of your eye socket, to make more of this hyaluronic acid here that causes muscle enlargement and fat enlargement. And that results in that bulging proptosis or exophthalmos of the eyes. And what that further does is it develops this scenario where you have so much pressure of your eye, congestion, you get tissue swelling, you start to develop bags above your eyes, below your eyes, you get edema and redness of your of the membrane covering your eyes, the conjunctiva. And you know, as Seth mentioned, you know, it looks like you've been on drugs, you haven't been sleeping, you look like you're high when in fact you're not. And the way I really think about this is that, you know, your eyes are on fire. It's almost as if you have a noose around your eyes and your eyes are just being bulged out and pushed out. And it is very, very uncomfortable. And of course, I don't have to tell any of the patients who may be listening to this what it feels like. I have never gone through this condition myself, and I hear through it through my patients, and I sympathize for all that you've gone through. So let's now think about what happens before any of the disease actually occurs, right? This is the pre-thyroid eye disease state here. And this is a scan of your eyes and your muscles here. What we're looking at on this upper left-hand corner here is the right eye here and the left eye here. And you'll see a couple little grayish slivers here. This is one of the muscles that moves the eye. This is another muscle that moves the eye. And right in the middle here, you can see this cable that's connecting the eyeball. That's called the optic nerve. And that's that important connection between your eye and your brain. And in certain conditions in thyroid eye disease, that can be affected. Here's another view when you're looking straight on at your patient here, right? And you can see all of 4 different muscles here in what we call cross-section. And this center circle here is the optic nerve, which corresponds to this right here. Now, in the TED state, this is what happens here. Again, remember on the top here, this is the normal setting. What happens with thyroid eye disease is you get buildup of all these abnormal chemicals and these compounds in your eye muscles, and the muscles get enlarged here. Look at this muscle here, look at these muscles here. Now look compared to the top here. You see how this muscle is a nice thin sliver on the bottom here? These are really enlarged here. And when it gets this big, your eye has no room to go except being pushed out. Another question and a symptom that my patients will often complain about is that, why do my eyes water all the time? The cornea is a clear part of the eye that we see through. And what can happen with thyroid eye disease is they can get dry, inflamed, and irritated. Why? Because you'll often get this condition here. It's called eyelid retraction. And anyone can see this from across the room that something is not normal here. We shouldn't see white above or below our eyes. And that's because the disease has caused our muscles to retract up, and it gives you that surprised look. And as Seth mentioned, what your patients will like to do is they like to cover up, they'll wear sunglasses. A lot of my patients tell me that, they haven't taken pictures in years because they don't want to be posted on like social media. They don't want other people to see and ask them, hey, what's going on? What's wrong with your eyes? And what happens is that when you try to close your eyes here, they can't close. And you can just imagine that when you go to sleep like this all night long, your tears are evaporating, you wake up in the morning, your eyes are burning, and you're putting in more teardrops in your eyes trying to help this. But it's this vicious cycle where your eyes are dry and irritated, you make more tears to sort of compensate for this, yet you can't retain the tears because they keep evaporating, and it's just an endless cycle of redness, tearing, and you're having to explain to your patients, I'm not sad, I'm not upset, I'm not on drugs, I'm not high. It's just that, my eyes are burning and irritated. And you can see how that can affect your work interactions, reading, watching TV, all the things you do in your day-to-day life. Another question that comes up, patients will ask me, is that, why do I see double? Now, this is just a view in a nice urban town in traffic here. This is not double. This is what most of us would see here. And if you have never experienced double vision, you don't really know what it's like to go through this. But if you're a thyroid eye patient and you have double vision, this is what you see. Now just imagine how hard it is to drive. Is there a car to the left of me? Is there a car to the right of me? Can I move up? I mean, it is very, very debilitating. So what you often end up doing is you end up covering an eye or putting a piece of tape over your glasses so that you get rid of that double. But then by doing that, you've lost some of your field of view, you've increased your blind spot. So it's sort of a small compromise to make here. And why do we see that? That's usually when there's a muscle imbalance. So you can see in this patient here in the upper left-hand corner, her left eye is pushed out or proptotic much more compared to the right side. Her eye is also rotated down. And when one eye is down and the other one's up, everything is vertical. You see two images up and down. On the lower right-hand corner here, one eye is deviated in, so everything is horizontally duplicated. And again, if we go back here to the patient with thyroid eye disease, you will see that when these muscles get enlarged, you can get asymmetric movement of the eyes. The eyes don't symmetrically move up together. When you want to look up, one eye goes up and the other one gets stuck in the down position. And you don't always get double vision looking straight ahead. You can get it in certain different views and gazes. And sometimes patients say that, gosh, when I look to the side or the periphery, it's just not as clear, right? And that's usually a tip-off that you're getting double vision, from thyroid eye disease. Another question that comes up, unfortunately, this is not very common, but patients will say, gosh, in one eye when I covered up, colors just aren't as bright. Reds are not as red, pinks are not as pink. Something is going on here, right? And if this ever happens to you, and, I encourage you every day to just cover one eye up and look at the other eye, look at something colorful. And if you see a difference in the color between the two sides here, there could be something very serious going on. And what we're always concerned about is a condition called optic neuropathy. Now, here's a diagram again of the eye. This yellow cable here is the optic nerve. Again, that is the cable that connects the eyeball to the brain here. with really severe forms of thyroid eye disease, when the muscles here get really large, you can see how there's the optic nerve. It can get so large and start squeezing on the optic nerve. And when that happens, that's where you start to get that impairment of your vision. And that's not something that we just sit around and do nothing about. That's something that really takes urgent action. All right. And so if you start to see that, please go see your eye care professional immediately. Another question I get, and I don't always, get asked this, but I often perceive this in my patients is why do I feel down all the time? Thyroid eye disease, as Seth mentioned, and a lot of my other patients over the years have told me, is that it affects almost every aspect of your life. Number one, of course, we know it affects the way you look, right? And sometimes patients are embarrassed. They say, like, I shouldn't be so vain. Why should I care the way I look? But it matters. When your eyes are pulled up, they can't close, they're red. You have to explain to your family members, your workers, when your eye's in pain, when you can't see the computer, when you look down at the keyboard, you see 2 keys, when your eyes are watering all the time, you're having to dab them down. This affects every element of your life. It affects your mood, the way you interact with your friends, your coworkers. It affects your relationships. And many of my patients, when they tell me these stories, they break down and they cry to tell me that, they don't spend time with their friends anymore. They're having marital issues. And it's this depression that really affects them profoundly. Our center did a study many years ago looking at, how bad the depression affects patients with thyroid eye disease. And it actually rivals having the diagnosis of cancer. So please understand and know that this is a medical condition. Thyroid eye disease is not a cosmetic problem. This is a medical condition that is affecting you. And patients will often ask me, they'll say to me, Dr. Korn, I feel like I'm doing this for cosmetic reasons. My insurance will never cover this. And I tell them, listen, you have a medical condition that has affected you, your normal condition. This is not the effects of aging, and all those other changes that occur. This is a medical condition affecting you. And no insurance company should ever deny you getting coverage to have medical treatment for this functional problem. So the next question I get asked is, when will this actually go away? Now, this is sort of a complicated curve here, and let me go through that with you. This is called Rundle's curve, R-U-N-D-L-E. And Rundle is a very wise physician who actually described how a disease actually presents itself, and in this case, an autoimmune condition. And what it basically shows you or illustrates is that when you look at a disease over time, it tends to get worse initially for a short period of time. Then it sort of reaches a plateau period where it actually stabilizes a little bit. And then you enter this period here where it actually has some slight improvement here. And in the case of thyroid eye disease, in general, the active phase is usually about half a year to about a year or so. And then after a year, you enter this, what we call quiescent or inactive phase, where the disease starts to quiet down here, but it never quite gets back to where it is in the pre-disease state. Right? And the typical way you manage this as a physician is during the active phase, you treat with very conservative measures, more supportive measures, right? In the case of developing optic neuropathy, sometimes we'll do early surgery or even do radiation. But really, when we think about the surgical management of thyroid eye disease, we want to wait till patients reach this inactive phase. And then we really do some of the reconstructive surgeries that can help the condition. And if you're going through this condition, it is very, very frustrating. And patients often ask, what can we do? It just really gives new meaning to the term being patient as a patient, right? No one wants to wait, and everyone wants sort of a rapid and quick treatment. But the general consensus in the past was to wait a period of months to years for the disease to quiet down. Then we can start to offer some of the different treatments. Now, what are the goals in the treatment of a patient with thyroid eye disease? Well, we want to restore normal visual function. We want to improve the bulging, the tearing, the watering, the eyelid retraction. And in doing so, we want to relieve a lot of the discomfort that you're having. We want to try to bring you back to the pre-disease state in the way you look. And ultimately, that'll help you to return to normal work, social interactions, and your relationships. So this is the treatment algorithm that I used, prior to 2019, just literally 6 to 7 months ago. And it's a 4-step plan. The first one is medical treatment of a condition. Next, once the patients have stabilized, we do an operation called an orbital decompression. An orbital decompression creates more space behind the eye to bring the eye back in. If you have double vision where your eyes are misaligned, then after the orbital decompression is done, then we do an operation called strabismus repair. And that's where the muscles of the eyes are detached, reattached, trying to get the eye to realign to the proper level. And then the last operation that we do is to repair the changes to our eyelids. All that tissue that is stretched, the tissues and eyelids that are retracted up and down, we approach this in that stepwise fashion. And the reason why we do this in a stepwise approach is that if we try to do the eyelid repair first before the orbital decompression, then doing the orbital decompression can change the position of the eyelids and the muscles. So you don't want to go out of order when you're treating patients from a surgical standpoint. So let's talk a little bit about the medical treatments pre, like 2019. The conservative measurements that, pretty much everyone should be on is to really keep your eyes nice and lubricated. I showed you that slide earlier of our patient who couldn't close her eyes. And lubrication is very, very important, particularly when you're going to sleep at night. Putting in a really thick eye ointment will keep that eye nice and moisturized. I've seen patients over the years who've had really dry eyes develop infections and even holes and perforations in the cornea and corneal scars that have developed. Another thing that we can do is put in plugs into the eyelid, and that prevents the tears from draining so they stay around a little longer. In more severe cases, you can even tape your eyelid shut at night, or even put on a pair of these goggles, like such as swim goggles, putting in some tears and moisturizing ointments in your eye to create a nice moist environment for your eyes so that you wake up, more refreshed. Some of the other medical interventions that you can do is taking an oxidant such as selenium. This was an article that came out in the prestigious New England Journal of Medicine a number of years ago. And it showed that patients that were given 100 micrograms twice daily showed some signs of eye improvement symptoms. But there's a couple caveats here. The patients that were studied were a group of patients whose diet was very deficient in selenium. And if you give quite a bit of selenium, it can also cause a little bit of gastrointestinal upset. So it can cause a little upset stomach. So, I do recommend it in my patients, use it judiciously. You can get a lot of selenium by eating a Brazil nut. So that's certainly an easy, natural way of getting your selenium. Another supplement that is gaining more recognition is vitamin D. And in a study that was recently published in our literature, thyroid eye disease patients were shown to have lower levels of a particular metabolite of vitamin D, 25-hydroxyl vitamin D. We know that vitamin D regulates many different things in our body, in particular bone metabolism and the immune system. This study did not look at the benefits of supplementation. All they showed was that in patients with thyroid eye disease, there's a deficiency of vitamin D. And of course, that begs, the next question is, should I be taking vitamin D? I think there's very little harm in taking vitamin D, in the proper dosages. So I do encourage my patients to take that in addition to selenium. Now, when we talk about medical management, I think no discussion is complete without the management or the mention of use of steroids, right? Now, these aren't the muscle building steroids. These are the glucocorticoid class of steroids, the ones that suppress the immune system. And then there's a huge body of literature of the use of steroids, particularly coming out from the European group, the UGOGO group. We don't use a lot of steroids in our center here at UC San Diego. I'm not convinced that it actually alters the course of the disease itself. And the use of steroids has many, many side effects, including the development of diabetes or worsening of the diabetes, hypertension. You can have damage to your joints and your bones. Patients who are on steroids have alterations in their mood, weight gain, and there are a couple of patients who have been on high-dose steroids who have even died from liver failure. So it's not a benign medication. The way we use it in our center is just very selectively in certain patients. We'll, instead of giving the oral dosages, we'll often give local injections around the eye itself, not obviously into the eye, but around the eye. And we'll use it as a temporizing measure if you develop that condition, optic neuropathy, that we talked about prior to taking you into surgery. Medications and supplements, if you just Google on the internet, thyroid eye disease supplement, you'll come up with pages and pages of different supplements. And these are just some of the many ones, different ones that are listed. My recommendations are always based on what's really been done in the scientific literature, something that has gone through the sort of the rigors of a good clinical trial. So even though there's a lot of these great supplements that are mentioned here, I can't advocate any of them because at this point, there's no hard scientific evidence to show that they benefit, thyroid eye disease. They may have certainly benefits in other conditions and other diseases. And I think with anything, moderation is sort of the best recommendation. So is there anything I can do now? Well, Seth mentioned smoking, and I cannot emphasize that high enough. Smoking really accelerates, and some of my patients who have the worst cases of thyroid eye disease, particularly those with optic neuropathy, are smokers. We don't really know what smoking does at this point, but it's thought that it really revs up the immune system. And we have an autoimmune condition like thyroid eye disease. The last thing you want to do is rev up the immune system, causing it to attack your eye muscles even more. I think really common sense things. Go on a healthy diet, right? At this point, there's no evidence, either pro or con, whether going on a gluten-free diet helps. Patients often ask me about that, and that's really described and written about a lot in the TED patient-directed websites. But again, just common sense, healthy diet, exercise, keep your blood pressure low, your cholesterol levels low. These are things that are just good for your body, and they likely have beneficial effects for your thyroid as well. So let's move back again to the approach that I took in 2019. That's the, once we do the medical approach, then we start to talk about patients who can have an operation called an orbital decompression, and that's in the reconstructive phase of the disease. Again, this is an operation where we create more space behind the eye socket to basically remove bone at various different parts of the eye socket. That creates more space in the house that really holds the eye in and allows the eye to come back in. And in general, the more the eye is pushed out, the more walls or bone that we actually remove. We don't actually take the eye out. What we do is gently push it aside, and we use very fine instruments that just sort of sculpt the tissues here, right? And here's a patient here who came to me before her condition with thyroid eye disease. You can see she has significant eyelid retraction and proptosis. And this is her about 3 months after an orbital decompression. Here's another patient with more severe proptosis, that really sort of open-eyed look. That's her after an orbital decompression. Here's another patient with really severe eyelid retraction and proptosis after an orbital decompression. And you can see that you get really good results with surgery. I think this is probably my worst patient that we operate on. This is a patient with a really severe unilateral proptosis on the right side. Her eye was pushed out, it was turned down. She had really, really debilitating double vision. And this is her after 6 months of rehabilitative surgery. So it took, quite a bit of work to really get her back to the pre-disease state. And this is a patient with eyelid retraction who underwent orbital decompression and then had an operation to lower eyelids. So, these are great operations, but if you're a patient who's had orbital decompression and strabismus surgery and eyelid retraction repair, you know that it's not an easy road, and it takes several months to get to where you need to be. And it's a good operation, but the question that we always ask ourselves as physicians is, can we do this any better? And can we actually do it without surgery? And that brings us to a new treatment paradigm in 2020. Again, I mentioned, in the early phase of the disease, We want to treat this condition medically. And prior to 2020, our best treatments were, steroids, selenium, vitamin D, radiation therapy. I'm not a big fan of radiation. I think, it certainly has its role, but, in our center, we don't really employ radiation. But as I mentioned, it's a waiting game. We want to wait for you to get into the inactive phase, which could be months or years before we can offer you an operation. Well, I'm going to give you a little update about a new treatment that has just been approved this year, and I'm sure many of you have heard of it, and that is teprotumumab. So let's go back to this, complicated basic science slide here, and go back to this cell here, the orbital fibroblasts. Remember, I told you that patients with thyroid eye disease have more IGF-1, insulin-like growth factor 1 receptor, on their cell surface. There have been, again, many studies showing that this particular receptor here is overexpressed. There's a lot of it on the cells. Well, there just so happens to be an inhibitor of this, or a drug that targets this. In this case, it's actually an antibody, what's called a monoclonal antibody, called teprotumumab, that actually blocks this. And when you give this molecule in cells in culture, you actually see there's decreased production of all these toxic chemicals that occur. Well, based on this basic science research, a clinical trial was started a number of years ago. And what it was is a randomized double-masked placebo-controlled trial. I mean, that's a total mouthful. What does that basically mean? Well, the gold standard for any new medication to be approved by the FDA, the Food and Drug Administration, is where you compare this treatment to what's called a placebo, where you give nothing and the medication itself. And then the patients that you choose are picked at random, so that the doctor and the patients don't really know what they're getting. And only at the end of the study is all that unmasked and revealed, and all the data is analyzed. And if you really take this, all these trials, and apply it to what's going on today with COVID-19, all these new vaccines that are coming out here that are being tried, they have to go through the same rigor from the FDA, because it's up to the FDA to make sure that something that is given to patients is safe and, importantly, is effective. So what they did in this study was they took patients with the worst thyroid eye disease. Seth talked about the acute symptoms: eyes that are pushed out, are red, inflamed, edematous. And they looked at patients who had a inflammation score of 4. Right? And I can talk to you about that briefly here. And they've had symptoms of thyroid eye disease for less than 9 months. And they compared what happens when you give this medication and a sham or a placebo medication. And here's the results of that. If you look on the top here, this is the placebo group. This is basically the patients that got a saline solution to the medication. You could see that baseline here, the eyes are red and inflamed here. And 24 weeks after getting a saline infusion, there's pretty much no difference in the appearance between the post-treatment state and the pre-treatment state. And of course, we don't expect that, because you're not getting the real medication. Now you look in the bottom group here, you can see in the pre-disease group, again, a really red, inflamed eye, but 24 weeks after the treatment here, much improved. The eyes are back in, the swelling is less, the eyelids are retracted less. And in all the patients in the study, there was a reduction in the proptosis, improvement in the double vision that is perceived by patients, a lowering of this thing called the CAS, which is a measurement of the amount of inflammation, an improvement of the quality of life based on surveys that were given to patients. And based on all this data, the Food and Drug Administration gave approval for patients with the diagnosis of thyroid eye disease starting in January of 2020. Now, the next question you should ask is teprotumumab, or it's called Tepezza, that's the trade name for the medication, is it the right medication for everyone? And of course, there's never, the right treatment for every patient. Some of the general considerations and things that we talk about in our patients is that, number one, we know that the IGF-1 molecule is very important for development. And it is absolutely essential that patients are on contraception. They avoid pregnancy for at least 6 months after the last infusion. It is absolutely contraindicated to give it to a patient who is planning to have children or in the childbearing age if they're not on contraception. So please, like keep that front and center in your mind. Because it does work on the insulin-like growth factor pathway, there's a slight risk for elevation of blood sugars, and it can worsen pre-existing inflammatory bowel disease. When you look at the adverse effects that was seen in the clinical study, the most common one were muscle spasms in patients that tended to resolve after the infusion stopped. So, we know that teprotumumab was looked at in patients with active thyroid eye disease. So the next question comes up is, what if I have chronic thyroid eye disease? I've been waiting a number of months or years, and now I'm actually planning to have the surgery. Can I actually go on teprotumumab? And remember, the clinical trial looked at patients who are in the active phase of the disease, who had an inflammation ranking of 4 or more, and had the disease for less than 9 months. What if you're a patient who's had chronic disease for a number of years, you don't have a high level activity, can you go on teprotumumab? Well, the FDA, when they granted approval for this medication, gave it a very broad label. You could have thyroid eye disease in any state. And based on that, our group actually took a patient and started her on teprotumumab, even though she was in the chronic phase here. And I'm going to give you a little sort of backstory about her case here that we published recently. This is a patient of mine who's 50 years old. She's actually had a 3-year history of thyroid eye disease. I've been following her for at least 2 years, measuring her serially, and I found that her eye measurements weren't changing, because when you treat thyroid eye disease, you want to make sure that all the numbers are stable, particularly with the eye measurements, because if you do an intervention too soon, you may hit the moving target. And she had an inflammation score of 1 because she was having sort of this constant ache in this left eye here. Certainly you can see that her left eye compared to the right eye was proptotic and pushed out much more. I had actually planned on doing an operation on her, but on the day of surgery, she actually was canceled for medical reasons because her blood pressure was too high and her thyroid levels were sort of out of whack. And right around this time, teprotumumab was approved by the FDA. She heard about it and she said, hey, can I go on this medication? So we went through the approval process and got her approved. This is her now before the treatment here. You can see that on her scans, her muscles are really enlarged, just like I showed you earlier here. Well, this is her now after 3 infusions. And if you look here on the left side, there is a marked reduction in the proptosis, eyelid retraction in her case here. She came in to me, she said, look at my eyes. I've gotten so much better. I can move my eyes more. I don't feel that pressure behind my eye. And then when you look at the scan here, you look at this red arrow here, look at the difference between this here and this here. We've decreased the muscle sizes by more than half here. All the muscles around the eye, right? And to me, this was that aha moment, even though teprotumumab was approved for active patients, it's working in this one chronic patient. But I always tell patients, you need to keep this in mind because this is just one case report, right? We really need to base a lot of our decision-making on bigger studies where we look at more patients to really get that good, hard scientific evidence. But at least this opened the pathway for other patients of mine to potentially get treatment here. So what should you do as a patient here? Number 1, don't smoke, keep a good diet, selenium, vitamin D. Keep in mind some of the really severe vision-threatening complications of thyroid eye disease, in particular, optic neuropathy. Take a look at the colors around you, the flowers, the roses. If these colors start to get faded, come back in sooner. Right? See your primary care doctor, your endocrinologist, make sure they keep your thyroid hormone levels intact. And importantly, I think it's important to seek a thyroid eye specialist who will look at your eyes both inside and outside and really start to discuss early treatment options because there's a lot of new things that are available on the horizon. I could end right here if you'd like me to. There's a lot going on, with COVID-19. I can talk about this, Susan, if you'd like me to, or we can enter into the question and answer phase. I've gone over a little bit, so.
Yeah, go ahead.
Should I go ahead?
Yeah.
Okay, perfect. Well, this is sort of the perfect storm right now that has come up, right? So much of the way we manage patients and patients are treated by physicians has changed with COVID-19. I can tell you with pretty good certainty that there's not a direct correlation between having COVID-19 and thyroid eye disease. There's no increased risk to be infected by COVID-19, if you have thyroid eye disease. I think it's important to keep your thyroid hormone levels in the normal range, because having normal thyroid hormone levels is optimal for your immune system. So if you keep your immune system in good check, perhaps you might have better protection against a potential COVID infection. We're seeing, as doctors, we're seeing fewer patients in person now, because patients are concerned about coming into the hospitals and the clinics. Well, I can tell you that our centers have been open, for many, many weeks now. And, we have extensive, social distancing, sanitary and hygiene measures that we take in the clinic. And, you hear in the news that there are a lot of patients who have been getting, I shouldn't say patients, but a lot of nursing care residents who've been getting infected with COVID-19. And I think the situation there is very different, compared to the clinical setting. That being said, we're still doing a lot of telemedicine with patients. And, if you don't feel comfortable, certainly reach out to your local doctor to see if they can just do a telemedicine visit. Because, as you know, with thyroid eye disease, you can often make the diagnosis just by looking at your patient and asking a couple of key questions. Another question that often comes up to me is that, if I get teprotumumab during COVID-19, this is going to suppress my immune system, right? Well, we know that teprotumumab works on a very specific part of the thyroid eye disease pathway, and that's the IGF-1 receptor pathway. We know that does not affect the systemic immune system. So, I think there's very little risk of getting COVID-19. In addition, some of our patients are actually getting treatment at home now with teprotumumab, so that even more decreases your potential risk for getting an infection. So with that, let me take some questions from the group. And again, thank you very much for your time and attention with this presentation.
Well, thank you so much, Dr. Korn, and thank you, Seth, as well. So we've been getting a lot of questions in, and I will start to read through some of those. We've got about a dozen of them so far, but I would still encourage you, if you have questions, keep sending them in. Some of these are a little bit duplicates, so we may not have to go through all of them. So I will just go ahead and get started. This, Dr. Korn, is for you. Can thyroid eye disease lay dormant and then kick up again?
Sure. So, thyroid eye disease is an autoimmune condition. So something like rheumatoid arthritis, celiac disease, sarcoidosis, scleroderma, these are all autoimmune conditions. And in many of these conditions, we don't know what part of the immune system is causing the problem. So we definitely can see flare-ups, where the disease lays dormant and somehow something kicks it up. It could be, an infection. Patients have often told us this. And when I first heard it, I didn't really pay too much stock to it. But when I kept hearing it over and over and over, it really triggered something in my mind. And that is the element of stress. And I think Seth mentioned this too. Whenever there's like a really stressful event in your life, the immune system kicks in, and, patients have noted sort of a flare-up of the condition. I can tell you that in treating patients with thyroid eye disease pre-teprotumumab, when we did surgery on patients, they do fine. We'd see them for a couple of months or years, and then sometimes I wouldn't see patients back for 5-10 years. And, at a certain time, they come back and say that, gosh, I'm getting more double vision, more diplopia, my eyelids are changing, my eyes are pushing out. So there definitely can be an element of reactivation. I think one element of that could be stress. It also could be smoking too. So, I mentioned this earlier, and I keep harping on it, but it's really important if you're a thyroid eye disease patient to not smoke. So you certainly can see a remission.
Okay. If you have thyroid eye disease, are you more susceptible to other eye conditions?
So with thyroid eye disease, when your eyelids are retracted and pulled up and they don't close, that leads to more dryness of your eye. And that's called exposure keratopathy. So just imagine what happens. When you can't close your eye is not being moisturized by the tear film. The tear film is really important to keep your vision clear, but it also protects your eye, because if your eye dries out, you can develop what's called a punctate spot on the eye. When that outer layer of that epithelium or that layer of the cornea breaks down, you then can get a bacterial infection and then can cause scarring of your eyes. And I've even seen patients when I've gone on mission trips and treated patients with thyroid eye disease who have developed permanent corneal scars in their eyes requiring a corneal transplant to fix. So certainly you can get that element of the exposure. The other issue I mentioned, of course, was the compression of the optic nerve, where you actually have, you can have permanent loss of your vision if it's not treated early. Another condition that we often see in our patients is high eye pressure. And you can imagine that when you get all this fat and muscle builds up that's pushing your eye out, it's in essence squeezing your eye. And what that does is it causes the pressure of your eye to elevate. And that in turn could lead to glaucomatous changes that have occurred. And we've seen in our patients who we've done surgery and orbital decompression is that the intraocular pressure, eye pressure actually goes down, appreciably. So that's part of getting a good ophthalmic examination to get your eye pressure checked and get your optic nerve looked at.
Okay. The next question is, can thyroid eye disease be passed on to family? So I guess, is it genetic?
Sure. Great question. So if any family members have, this condition, one of the first things we tell patients is it certainly can run in families. And then the next thing that happens is they call their relatives, their sisters, their parents, have you ever had this? Sometimes they go back and look at old family photographs and you can see the eyelids are retracted in family photographs. So there's definitely a genetic component. But that being said, I've also seen patients who are identical twins. One has a condition and the other one does not. So that definitely tells you there's an environmental component here. And one that we don't really have a good idea of what it is. I think smoking could certainly be one, maybe dietary insufficiency of selenium, vitamin D, and maybe some of the other factors that can come up too. So, it's not just genetics, but, we definitely know there's a genetic component, but there's no genetic test that's available yet.
Okay. What medical specialties or specialists treat thyroid eye disease?
Sure. So there's several different types of doctors who can treat thyroid eye disease. And, oftentimes when patients come to us, they've been to many different doctors along the pathway. I can't tell you how many times patients have come to see me with a red eye. They've been on anti-inflammatory drops, steroid drops, tear drops. They're given this by many different eye care professionals or primary care doctor, only to find out that they have a little eyelid retraction, a little chemosis, a little swelling in their eyes, and a little double vision, and they turn out to have thyroid eye disease. So, it can often present to us in many different ways. I say in general, oculoplastic surgeons, including neuro-ophthalmologists, will treat thyroid eye disease, and strabismus doctors too, who treat double vision. And we often work in concert with each other.
Seth, I'm curious on your perspective on that. How was it that you found the right doctor to treat you? Because I think that you moved in the process, I think, when you were in the active phase as well. So that was a little bit difficult. So can you just speak to that from the patient perspective?
Sure. So Susan, initially I met with an ophthalmologist that was not licensed for doing oculoplastic surgery. So that was kind of my first touch point with an ophthalmologist. And then that was in New Hampshire. When I moved to New York City, probably 18 months later, I moved from the active phase to, the inactive phase where I could actually have an orbital decompression surgery procedure. And at that time, I met with a different specialist, of course. So in addition to that, I would say just in general, you might have to interview or meet with more, the same type of specialist, but just kind of interview them until you find one that you feel comfortable with, that, if you're considering a couple of different types of treatments, you want somebody that's going to work with you and maybe not force feed you one that they believe in strictly as kind of the cure-all.
That's super important. Very good point there. Dr. Korn, someone asks, does Tepezza, this new medication, improve double vision?
So in the clinical trial that was just published, there was a qualitative improvement in the double vision. We are looking at this in our patients as well. The studies actually didn't look at a specific number in terms of the measurements of double vision, but there was a subjective improvement in double vision. And I've also heard this in my own patients too. And you can imagine that, when your eyes are pushed out, right, it's hard for the eye muscles to move, sort of in a natural configuration. But when they're brought back in a more natural condition, the eyes can move a little bit more naturally here. So, one certainly would expect that. I know in my own patients who I've treated with Tepezza, they have had an improvement in their eye movement. It doesn't get rid of it in every patient. If you have that, really, really severe proptosis and really severe eye misalignment, sometimes you will need an operation to really get that eye back into its complete normal position.
Okay, I had another question that just came in. Is it common for a stringy mucus to be pulled from the eye of a person with thyroid eye disease, or is that a sign of allergies?
It could be anything. So when your eye is inflamed, whether it's from an infection, whether it's dry, your eye will make more mucus. And that's sort of a protective mechanism. So that tells me that, likely the eye could be really dry. It also could mean that there could be a blockage of the tear duct, the eye could not be closing. I mean, there's many different explanations for that. I would say, the proper thing to do is to see an eye care professional for them to check that out.
Okay. We had a question from a patient that says, what can be done to help with eye pain? I get headaches from double vision and my equilibrium being off.
Mm-hmm. So there's lots of reasons why you can have eye pain. I touched on earlier, if your eye's not closing, it's going to hurt. The nerve fibers on the eye are probably the most dense in the entire body. And it's, Mother Nature designed that on purpose. If you get something in your eye, what's the first thing you do? You blink to protect your eye. You could take a wisp of, cotton and just barely touch the eye and the eye will blink. So if the eye is dry and exposed, you're certainly going to have discomfort there. The next element is that feeling of congestion. And maybe Seth, you may have experienced this yourself when your eye is really proptotic, particularly in the active phase, when it's really congested, it just hurts to move your eye. You get this general ache that is just nonstop in your eye. And then you get sort of that pain from not being able to realign your eye. And what happens is when your eyes are misaligned, your brain really works overtime to readjust and to straighten your eyes out. And you can get this, really, it's called eye strain, where you get this generalized ache from just trying to see a clear image. And, if any of you who are going through the reading glass phase, which I'm going through, trying to read up close sometimes, without your readers, you find that you get this same type of eye strain. So there's many, many reasons why you can get eye pain. I think, number one, check your ocular alignment. If you have misalignment, you can get these things called prisms to put in your eyes temporarily that'll help you to realign your eyes, put artificial teardrops, do sort of just common sense measurements. Take breaks, don't spend too much time on your smartphone, you're on your screen, just general things that I tell my kids, to avoid eye strain.
Great. I think it's called the 20-20-20 rule. Every 20 minutes, look at an object 20 feet away for at least 20 seconds.
Right.
Yes. Okay. Somebody asked, I've had one eye that is always swollen for about 2 years. Should I seek treatment or let it be? The symptoms are mild to moderate depending on the day.
Sure. So whenever you see, thyroid eye disease in general affects both eyes. Now, it can affect one eye more than the other, what we call asymmetric disease. And a lot of the patients I showed you had some asymmetric disease. But whenever it affects one eye significantly more than the other eye, we always think in the back of our mind, could it be something other than thyroid eye disease? And so what I do in patients who have sort of an atypical or unusual picture, one eye is pushed out more, yet we check all the thyroid labs, completely normal, TFT, thyroid function studies, all the measurements are normal. Then I start to think in my mind, there could be something else masquerading as thyroid eye disease. So we'll often get a scan and take a look at the configuration of the muscles. And if something looks unusual, we'll go in and do a biopsy. And that's basically taking a little small section of this tissue and looking at it under the microscope to find what the cause is. And I found many patients over the years who have had occult cancers that were not picked up and other conditions that were not thyroid eye disease. So whenever there's a condition that's just one eye, please go see your local doctor and make sure that they do some imaging tests and blood studies to make sure that you actually do have thyroid eye disease.
Okay. This is kind of a follow-along question, I guess, maybe just kind of clarifying the relationship between thyroid eye disease and, Graves' disease. So it says, when you are having active thyroid eye disease, does that mean your thyroid levels may be elevated also?
Yeah, great question. So in general, the immune system is mediating this, right? So, it makes good sense that if your immune system's revved up, your thyroid levels are probably, out of tune, and probably your eyes go hand in hand with that, right? But not necessarily. I mean, you can certainly have like normal thyroid levels. We call that euthyroid eye disease, yet still have inflammation of your eyes. So I wouldn't say they always go hand in hand, but they typically do.
Okay. How long does it take for the infused therapy to work? How many infusions?
Sure. So teprotumumab, as indicated on the FDA label, is given as a series of 8 IV infusions, and those are separated by 3 weeks. So the full course is of course 24 weeks, right? In our patients, we notice an improvement usually around the second or third infusion. But again, we've only treated about a dozen or so patients, at least, in my hands. So, I think sort of the jury is still out. And this disease is very heterogeneous and it's very different. I think some patients will get a more robust response earlier. Others may take a little longer. But we're following, the full 8-week course, the 8-cycle course to really look in our patients to see what the clinical effect is.
Okay. So I'm just scrolling through our questions. Here's another one. If someone has repeated eye surgeries, can that contribute to the failure of the eyes to close properly when sleeping?
So, I'm in Southern California, and, in addition to thyroid eye disease, I do a lot of, functional and cosmetic surgery of the eyes. And, some of the patients who come to see me have had rather, aggressive eyelid surgery, sort of where their eyes are open, quite a bit. So sometimes they've had 4 or 5 operations and they come to me from a reconstructive standpoint to fix, and these are really challenging cases. So I think, certainly the more surgeries you've had anywhere in your body, there's more scar tissue, there's less blood supply, there's less sort of plasticity of the tissue. So I think it gets tougher and tougher, every time you try to operate on an eye that's been, operated on multiple times, or any tissue, around the eyes or face.
So here's a question. It just says, can teprotumumab be used to treat thyroid disease, or is it just for thyroid eye disease?
Well, I can only comment on, my patients who I've treated, and knowing that the IGF-1 receptor, is present in the orbital tissues. I will tell you though, in a lot of patients who have thyroid eye disease, they can also get enlargement of other tissues around the eyebrow, tissues around the cheek, and even along the shins too. There's a condition called pretibial myxedema, right? And if you have Graves' disease, you might notice some swelling of your shins. I've noticed in one of my patients that actually she had reduction in the swelling around her eyebrows and her cheeks. So I think there could be another biologic effect, but that really hasn't been studied yet. And I think, the indications here are really to treat patients with thyroid eye disease, treating the eye condition, not the actual thyroid itself. I don't think that would be a proper, use and indication for the medication.
Okay. Got a couple more questions. For a patient with severe thyroid eye disease who has undergone both decompression and strabismus surgery, what is the possibility that Tepezza could improve their persistent double vision that remains even after the surgery?
Sure, that's a really good question, and we don't really have the answers to that yet. All right, and so I think as with anything, right, we really have to let more sort of clinical experience come out from other clinicians who are using it. We collate all these studies together, and then we can really come to some consensus. I know that at least in my patient population, I've had some patients who've had surgery many years ago who are undergoing Tepezza. I can't give you any information yet because it's still too soon to say, but I honestly don't think there's a reason why you can't undergo the treatment if you've had orbital decompression or strabismus surgery before.
Okay. We have one person that says they're using Restasis.
Mm-hmm.
I'm wondering if that's a good treatment for some of their eye problems.
So Restasis is cyclosporin. It's actually a anti-inflammatory or immunosuppressant, and it's thought to help production of more tears around the eyes. I have some patients who are on that. I can't really opine how well it works. I know some patients are on it. If it helps you with your dry eye, certainly I would continue it, but I wouldn't say, it's the indicated treatment for thyroid eye disease, but it's a very good medication, and it really helps if you can tolerate some of the stinging and irritation that occurs from the medication to help you produce more tears to keep your eye more comfortable.
Okay. And we've got just a couple of more, I think, here. One patient's asking, should they consider LASIK kind of while they're going through this?
So that's actually a really good question. So, some of my patients who have, their eyes are really prominent and proptotic, they said, I want to get LASIK too. That's going to help my vision, right? That'll help my double vision, right? When you do LASIK, what you're doing is you're cutting the outer layer of the cornea. When you do that, you're actually interrupting all the nerve fibers that actually give you a sensation of the eye. That's actually not a good thing, because if you can imagine, if your eyes are dry, they can't close, you should be able to feel that. And you need to know that your eyes are uncomfortable so you can put drops in. If you do LASIK, one of the biggest side effects of doing LASIK is dry eye, because your eye is just not sensing that and you're not making enough tears. So in the setting of thyroid eye disease and LASIK, I tell my patients, don't do LASIK, right? Now, after you've had the treatment, your eyes have come back in either through medications or surgery, and they can close properly. And if you have a normal, healthy tear film, yeah, you can have LASIK, but don't do it if your eyes are not closing. That is absolutely contraindicated.
Okay. Can diet impact thyroid eye disease? They ask, is an anti-inflammatory diet good for it?
Right. Again, we don't have the studies to really ask the question, does it help or does it not help? And the gold standard way of doing that is to pretty much take the identical patient, put them on one diet, anti-inflammatory, the other one sort of a low sugar, low inflammatory index diet, and you really can't answer that question. However, in general, as I mentioned earlier, a good diet, good control of your blood pressure, cholesterol, going on an anti-inflammatory diet, I think is intuitively good, right? I would never talk a patient out of going on a anti-inflammatory diet. So I certainly encourage you to do it if you like to, but don't do it thinking that it's going to cure your thyroid eye disease or make it better, right? Know that you're doing that because it's good to reduce inflammation throughout your body, good for your cardiovascular system, and so forth.
Okay. Seth, this question is for you. Did you exercise while you were dealing with thyroid eye disease? And if so, did you find it beneficial?
I definitely was active before and during. However, I'll say that I dialed back my cardiovascular. So like I was a runner, I had joint pain, and I was already burning more than I was, I was losing weight pretty rapidly. So what made sense for me was doing some weights, and even with that, I still had some issues with my joints. So I tried to stay as active as possible, and I think it was beneficial both from a physical health as well as mental health standpoint. So yeah, I would say being a couch potato was not going to happen for me. And although it could be easy to want to bury your head in the sand and not necessarily go out and be social and active and all that, I still found ways to get out and about and do things that I liked before I was diagnosed. And eventually you can get back to resuming your normal life, so to speak. But I think a big part of it is just coming to terms with your appearance and the new you, and just saying, hey, this is reality. It might be a year, it might be 2 years, whatever the case might be. And I think once you come to terms with that and understand that you're kind of locked into this, for a couple of years anyhow, most of the time, then you're in a better position to, be yourself and adapt as necessary.
Great. We've gotten a couple more questions in, and we have just a few more minutes. Dr. Korn, does Tepezza permanently block the antibodies that cause the swelling? And can you go through the treatment a second time if needed?
Sure. So, the treatment is giving a synthetic antibody into your bloodstream. The reason why it's given, over, a 24-week period is because you give the medication, it has its biologic effect, but your body clears this medication, so it does not stay around forever. And in no means are you permanently stopping the autoantibodies. all you're doing is really blockading their effect on the orbital tissues of the end organ tissues. So you're not getting rid of any component of that. And that certainly begs the question that was mentioned later, was that, can you get retreatment? We don't know the answers to that, but in my mind, there's no reason to think that we cannot undergo treatment again. Because, think about this. If you have arthritis pain, if you have joint pain, does that mean you can just take one ibuprofen and you're done with it? No, you take the medication, it controls inflammation, and then if the inflammation or the joint pain comes back, you take another ibuprofen. Teprotumumab or Tepezza is not like an ibuprofen. I mean, it's certainly not in the same class, but think about that in that way, that, you have a chronic disease and it can certainly be retreated if necessary.
Okay. Someone says, if 50% of Graves' disease patients develop thyroid eye disease, then what are the chances of recurring TED after thyroid levels treated go back to normal and your Tepezza treatments have been successful?
$1 million question. Again, we don't know. The only way to really know that is to have hundreds of patients on the medication and you really follow them like over time. And, disease reactivation is often a question that comes up. And, in the pre-Tepezza days when we treated patients with surgery, I would estimate that about 5 to 10% of our patients reactivated over their lifetime, right? That's just based on, my experience in seeing thyroid patients over around 15 years or so. But, now that Tepezza is out there, I actually think the medication is affecting and changing the fundamental biology of the disease. And the way I say that is that I've never seen a treatment that you can give to a patient that actually makes the muscle shrink, to their almost to their original size, bringing the eye back in and improving their movement. You can't do that with steroids. Radiation has some effects, but I think to see that profound change in a patient who's had that disease for 2 to 3 years that I showed earlier, really to me said that this medication is really fundamentally altering the biology of the disease in our patients.
Okay. I think we're going to just end with one final question here. Are there other common comorbid conditions that go along with thyroid eye disease?
Sure. So, thyroid eye disease is an autoimmune condition. So oftentimes, a lot of my patients have other associated autoimmune conditions, rheumatoid arthritis, sarcoidosis, scleroderma, psoriasis. These tend to go hand in hand. The thing I always want to tell patients is, even though you have thyroid eye disease and it's just causing your eyes to bulge out, as was mentioned earlier, make sure you get a really thorough eye exam. Make sure you get your optic nerve checked, check your eye pressure, and make sure you're not developing glaucoma, because that can be a very silent condition. Having glaucoma is a silent killer. It silently takes your vision away. Patients typically don't have pain from glaucoma. You can have an elevated pressure for years and years and years. It can cause slow loss of your optic nerves, and you'll never know it until you take a visual field test. And by that time, it's too late to intervene. So, it really emphasizes the point: see an eye care professional, make sure they do a comprehensive eye exam on you when they see you.
Very important to do that annually.
Yes, absolutely.
All right, well, we're about out of time and we've gotten through a ton of questions, which is great. So I really want to thank everybody for joining today and thank Dr. Korn and Seth for lending their expertise both as the clinician and also as the patient who's come through on the other side. We encourage everybody to visit visionhealthadvocacy.org for more information, and everybody sometime in the next week or so will receive a follow-up email from me as well. There'll be a link to view this webinar online. And we just thank everybody for joining us, and we hope you all have a good rest of the evening.
Thank you. Good night. Appreciate everyone for staying.
Thank you.